we have seen lung cancer and kept the records of lung cancer as it occurs in the country. You see, one important thing we are trying, the first documented lung cancer report in Indian literature is way back in 1935 when Agarwal, Saraswat, but they are only the case reports or few cases. But actual attention was given by late Dr. Viswanathan, who in 1961-62 reported a series of cases. Then throughout the country, from all parts of the country, from all medical colleges, the case reports came in and pouring in fact. So by far the largest report was from PGI, the largest series. But the good thing again, as I said to you, the ICMR Atlas Cancer Atlas program or the registry program, both hospital-based and the population-based cancer registries, they all they are getting good data. So we are getting the information. So obviously, smoking is one of the commonest factors, although a larger chunk also occurs in non-smokers, particularly in non-smoking females. The exposure to biomass fuel, exposure to second-hand smoking, various other pollution-related issues like both indoor or outdoor occupations, certain chemicals, etc., and then the old fibrotic lesions, what we call as the scar carcinoma. So there are various causes, although still common is the the smoking, which still is continued. And same thing is of the median age. It is about 58 years in case of males and slightly younger in case of females. And you see in earlier years, so if I divide you the era of lung cancer into three different phases, before what was happening 2000, then 2000 to about 2015, and then 2015 onwards. So what we will see that squamous cell carcinoma in earlier periods was the commonest form of cancer. About 48 to 50% will be squamous cell carcinoma. Then in the middle part, the middle age, or what we should say between 2000 onwards, we saw that adenocarcinoma incidence started rising. It started rising, and now, as per our cancer registry data of ICMR, that shows adenocarcinoma is the commonest form of lung cancer in India. And in case of females, of course, the non-smokers, it is the commonest form of cancer. But what is most important to note is the adenocarcinoma. This was seen few decades earlier in more developed countries, that is in USA, then the European countries and some Japanese countries, in Japan and other countries. So now actually we are trying to catch up with them. So maybe, of course, there are various factors why adenocarcinoma is increasing. So that I am not going to discuss because of the time allotted to me. So this is the third aspect, I should say. What in India we are seeing is there is a sudden explosion of the investigations. We could diagnose these cases more and more. I should not say that we are diagnosing them more early or in earlier stages, but we are able to diagnose them most of the time. Various diagnostic facilities, particularly the young aggressive pulmonologist in the country, availability of various modalities, that is again helping us to get a diagnosis, getting an adequate tissue. And the third important point which I like to tell is the development in the field of lung cancer. In the earlier years, for about a very long time, the median 5-year median survival in lung cancer world over, it was hardly 8% to 10% of the people who were surviving for 5 years. But now with the understanding of discovery of biomarkers, newer biomarkers, say for example now you have got 7 gene mutation, you have 9 gene mutation, the commonest ones being the EGFR and ALK, and then of course the other rare mutations that you almost know. And the second thing is the PDL1, or that is what we call the development in the immuno-oncology. So getting the PDL1 levels and treating them with the immunotherapy. So there the median survival has now increased tremendously. Now you can count them in years, the overall survival, the 5-year survival. So that has come. But the only thing which I still notice, there are still many cases, about again 80-85% of cases, they are present in a very late stage, that is stage 3A, 3B or stage 4 disease. And then the surgery, a very small percentage of cases could be amenable to surgery.
Yes, sir.
So that is what is the overall picture I try to give you about lung cancer in India.
So as sir has said that the burden of lung cancer in India is too much, and we are diagnosing most of the cases at the late stage or the stage 4 when the patients become symptomatic. So screening is very, very important, but lung cancer screening guidelines are mostly the international guidelines, which are based upon few landmark studies. So to begin with, we would like to have an idea upon what were the landmark studies and what were the conclusions, so that on that basis we could take out the points, which population should be screened and what should be the screening criteria. So first I would like to ask Dr. Logan to put a light upon few landmark studies and what were the conclusions in brief, sir, please. Yeah.
Thank you, Dr. Sweta. As Dr. Professor Begara sir was telling, the lung cancer is the number one, and they present late because by the time they present with symptoms, either the disease is locally advanced or distant metastasis. The why this is important is by the time they come with advanced disease, for example, stage 3A or more than that, the successful treatment for lung cancer becomes very less. And as sir was rightly pointing out, nearly 80 to 90% of the patients which we see are in advanced stages with very less, outcome. What is the solution for this? That's where the screening comes. So the screening, obviously, even though it has limitations, there are various methods of screening for lung cancer. Because this disease is particularly apt for screening because of various reasons, because it is common, it is important public health problem. 2, number 3, there's high morbidity and mortality, and we have a high risk category. What is the high risk category? Most important is the current smokers with more than 20 pack years or more than that, and also the former smokers, especially those who have quit within 15 years. And as sir was telling previously, also you have other risk factors like chronic lung disease, interstitial lung disease, exposure to the asbestosis and family history and so on. So there are various methods of screening of lung cancer. You have
trials.
Yeah. So among the trials, amongst the various methods, you have chest X-rays, sputum cytology, ball samples, bronchoscopy, and so on. And coming to the trials per se, there are a few landmarks trials. The NLST trial, which came in early 2000, the 2014, and you have PLCO trial, you have the Nelson trial, and other trials. Coming to the PLCO trial, which was earlier started than the National Lung Screening Trial, it was they have not chosen the denominator population is more than 150,000 people or so. 153,000 something people is the denominator population. It is the prostate, lung, ovarian, the colorectal cancer screening program. There they found they compared in a healthy population, it's not a high risk population, it's a healthy population of 153,000 or so. They compared with the chest X-ray versus the usual clinical care. And they found at the end of the day, the outcome of the study in terms of the mortality, it has not shown significant benefit at the end of the day. This was changed, this study PLCO trial was planned for, up to 2015. But it was stopped earlier because of the outcome interim analysis, which was published in NEJM in 2014 or so, the NLST trial. This, trial, the National Lung Screening Trial, they incorporated nearly 53,000 people. It was randomized trial. They compared, they chosen the age category between 55 to 74 years of significant high risk behavior group, that is more than 30 pack years group. So that was the inclusion criteria. One group was allocated, nearly half of the population allocated to the low dose CT screening, annual screening up to 3 years, and then follow for 6 to 7 years. The mean follow up in that study was 6.5 years. Another group, the chest X-ray group. The positive the LDCT in that trial was taken, 4 millimeter non-calcified nodule in the CT was taken as positive. The chest X-ray, any visible mass or a non-calcified nodule, which if it is visible in the chest X-ray, is taken as a positive sign. The T0 is the time in the first year screening, T1 is the second year screening, and T1, T2 is the third year screening. The problem in this trial was, nearly 96% of the population, the screening population had a positivity for the LDCT, whereas 94% in the other trial, other chest X-ray group. But in this, majority of them are false positive. False positive. They found at the end of the day, the nearly 1,061 people having cancer in the LDCT group, whereas 900 plus patients had cancer in the chest X-ray group. And those who had a positive sign, positive finding in the CT, they have submitted to various kind of the evaluation, either percutaneous sampling or bronchoscopy guided sampling or a surgical lung biopsy, depending on the facilities available in that particular center. Because when this study was started, there was no standardized, the structured program for the follow-up of lung nodule, solitary pulmonary nodule, as it came later on. So once a positive nodule is found out in the CT, it was left to the treating unit, the trial center to carry on at which pathway they want to evaluate this particular positive nodule. But at the end of the study, they found significant relative reduction in mortality up to 20%, which was significant between the LDCT group versus the chest X-ray group. I will not go into the detail. I'm sure it will be discussed subsequently. The this interim analysis came before the completion of PLCO trial, and they stopped PLCO trial, and this became the screening modality later on. So NLST has revolutionized the screening of lung cancer in high risk population. After that, the Nelson trial came from the Netherlands group. The number of people who have screened in this population, nearly 15,000. The age cutoff limit is slightly less than the NLST trial. It was, the 50 to 74 years. In this group, also they found that the low dose CT is superior to the usual care of treatment. Then came the Dandy trial, and the problem with the Dandy trial was, it was not adequately powered for the study outcome. Then came the Danish trial, the DLCSC trial. Even though it has the CT, they found out the positive nodule. It was not an adequately powered study to find out to reach the outcome. Then came the Lucid trial, the Germanian trial, then the MILE trial, the multicenter Italian lung reduction study. All these are, even though they've included the high risk group, people with history of current smoking, as well as with the history of smoking within the last 15 years, these studies are not adequately powered for the suitable outcomes. Then came, the UKLS trial, the UK lung screening trial. The major difference about this particular trial comparing the other trials, here the inclusion criteria in this particular trial, apart from the smoking history, they've included other risk factors for lung cancer, as that Professor Beresar was telling. The family history of smoking, family history of lung cancer, and the history of exposure to asbestosis, and the history of lung disease, and so on. So they have included it was the Liverpool Lung Project. So they have included the other risk factors for lung cancer also. So to put it in a nutshell, these are important few trials. There are so many trials, but all are, carried out in the population less than 5,000. The largest trials are the NLST and Nelson trial. But we have a meta-analysis of all these trials, which says that chest X-ray is not the screening test of choice for various reasons, even though it is cheap, easy to perform, but it is not picking up the early stage lung cancer, which was seen in the low dose CT group. And so those are some of the few trials, if I need to mention now.
Yeah. So basically, the trials laid up the background for the various international guidelines for lung screening that has come up. And you have beautifully told about the risk factors also that are there apart from the smoking, that if there is a family history of any kind of lung cancer, the patient is having any other kind of cancer, asbestos history, history of radon or exposure history. So these are basically the risk factors available. So coming on to the next question, like for example, a patient comes to me and he is a 55-year-old male with a pack years of say 30 pack years with he has left smoking 5 years back, diabetic, hypertensive. So he has come to me in the OPD for some other non-specific complaints. So is there any objective criteria or any subjective pre-test probability criteria which are available, or any screening scores that are available? So Dr. Lakshmi, would you like to comment upon this?
Sorry, I missed the question.
So how to calculate the pre-test probability for the malignancy, whether the patient has come to you, how do you calculate whether the patient has low risk, moderate risk, or high risk for the malignancy, the lung cancer specifically, and any scores that are available?
Yeah, see, there are 6 or 7 scores which are available to screen to identify the probability of having cancer. However, they are, to my knowledge, are largely based on one risk factors, which already have been included in the trials, and they form the criteria for deciding the screening. So we can go by those. But once we find a nodule on CT scan, then moving forward, what is the probability of that nodule being malignant? There are again another set of calculators which give us the probability of it being malignant. However, again, they are going to be very tedious to use, though there are some which are available online, and you can easily calculate the probability of having cancer.
So there are a few clinical models, clinical probability scores that are available, like VA score or Mayo Clinic scores are there, but they are all in the American population. They may not be applicable for our kind of population, and that they are not validated in our population. So we have to depend upon our clinical judgment, what is on the basis of the age and the smoking history, that what is the clinical probability of the patient. So next question is very, very specific, like who should be screened for the lung cancer? Like what are any recent change in the screening criteria? What are the 3-4 points, screening things that the patient is in front of me, I should know that these are the 4 points, patient meets these criteria, and yes, he has to be screened. So Dr. Ankit, can you please tell about this?
So basically the UPSTF has come with newer criteria in March 2021, and they have told that any person which is aged between 50 to 80 years, who has a history of 20 or more pack years, the smoking history should be there, and either he should be a current smoker or have left smoking within last 15 years. So there is a change they have from 2013, the changes have been occurred. Earlier it was from 55 to 80 years and the pack year was 30. And why they have changed? Because for the pack years, there they have a very varied population was there, because the black Hispanics were there in the US, and that's why their smoking is much lesser than compared to the white person, and that's why they have reduced their pack years from 30 to 20. And for the age also, they have reduced the age from 55 to 50 to increase the number of the screening population can be increased, so that mortality rate, what they have see that in the last 8 years. So that mortality rate has decreased from 13.8% to 6.5%. So that's why they have changed the screening criteria for 50 to 80 years, and the pack year is only 20 or more, not 30.
So now we have a definite criteria of age limit between 50 to 80. smoking pack is more than 20, and the patient who has quit smoking less than 15 years of age. So these are the three clear-cut criteria. If these are present, then we should definitely screen for our patients. But suppose I just discussed, like I have a 55-year-old patient, but on the other hand, next patient comes, he's 81 years of age, he has a smoking pack years of 30, and he has left smoking 5 years back. So will he be screened too? So who are the population we are not supposed to screen? Because screening will definitely pose a financial burden. So who are the people who should not be screened? Dr. Mahendra sir, yeah, you can answer, please.
So,
Please.
the variable addressed by the step by step, the risk assessment. First of all, need to understand risk assessment, then the high risk group and the low group, previous guideline, this guideline, and who are not eligible candidate for the lung screening, because the lung screening is an ongoing process. So shared decision making protocol should be prepared. The patient who already diagnosed lung cancer and on the treatment, he should not be the eligible candidate for the lung screening. And the person who diagnosed and taken treatment and under the surveillance, that has not been addressed into the NCCN guideline also. And the patient having or any person with a functional status and who's having comorbidity, that will not allow for the screening. These are some important factors for which this screening is not going to be help much, and the patient not willing, also not giving consent. Because if we discuss with the patient what is basically screening, why we are going for this. So there is a long process to go, years, cost, so many things. Risk and benefit analysis should be discussed with the patient. So these are the 3-4 points which is not allow for this.
Not to be seen. Dr. Ankit, you wanted to say something here?
Yeah, the same thing, that where the person, if have the quit more than 15 years, he shouldn't be. And if he have any health problem and the life expectancy is not much, which that's why. And the third point is that if he's not willing to the surgery. So these are the 3 basic points. If we shouldn't be screening. Or if we are screening, we should be stopped.
Yes, sir. And if the age crosses beyond 80, then also is one of the, yes. Okay. Thank you very much, sir. So now
the point is not, Dr. Sudha, the point is not the age is 80. The screening is designed, they design the risk, low risk group and high risk group, and what up to the level 77 years, if the functional his condition is okay, then
function
he can go.
Yes, sir.
But the thing is, if the surgery is designed, then why we go for this thing? So the message is clear. Patient number 1, patient should give consent, and he should be under the category.
Okay, right, sir. Right, sir. Thank you very much, sir. So now we have decided that yes, we are going to screen this patient. So what are the modalities for screening that are available to us, and which one is a preferred one, recommended, and the validated one? Dr. Logan, please.
Yeah, so the first question of you is, what are the screening methods?
Yeah.
Yeah. So
what are the available? Because CT may be.
Yeah. Sorry. So there are various methods of screening. The sputum cytology, chest X-ray, low-dose CT scan, and the sputum analysis in the bronchoscopic lavage samples, ball samples, and the various tests done on the bronchial epithelium and the mucosal, including the buccal mucosa samples, and exhaled breath analysis, condensate analysis. So coming to I'll put nutshell about all these points. I'll not touch upon the various other newer things which are coming in the non-radiographic methods, because
which are easily available to us.
Yeah, there are no much data like the sputum cytometric analysis, the analysis of P16 hypermethylation products, P53 mutations in the sputum analysis, and the exhaled breath condensate. All these are new coming one. We need more data on that. And also the various tests done on the bronchoscopic lavage samples over the bronchial epithelium, as well as in the buccal mucosa, including that. we need more data on that, but few things I'll touch upon the and also the autofluorescence bronchoscopy. So these are the screening modalities studied in various trials with not much of a positive outcome. But I'll touch on three things. Important things are sputum cytology, chest X-ray, and the low-dose CT screening. We have there was a study which was taken by the Mayo Clinic previously by utilizing chest X-ray, and also the studies later on which came from the New York and other areas. They found initially chest X-ray detects masses, nodules, but it won't pick up the lung cancer at the early stage, which is the importance of a screening. The screening, it should be ideally it should be done in the healthy population, in good health, with those people who have a high risk behavior like history of smoking, significant current previous smoking, and other risk factors. And it should pick up the disease very early, and it should be treatable with minimal mode of therapy, minimal resection, and or else the other curative mode of therapy which is not exhaustive, and it should be a morbidity mortality benefit at the end of the day. It should be cost effective. It should be applicable to the larger population. So these are the few things we have been taught about the screening procedures in community medicine, but this was not satisfied in the chest X-ray group, because obviously it picked up the disease at late. We also see the chest X-ray, when once you see the nodules or masses, either they have symptoms related to the local metastasis or advanced, either a local regional disease or advanced disease, if you start evaluating. And also in the PLCO trial, they found that it was also stopped. We have discussed previously, it did not have a positive outcome. But the sputum cytology also, for example, if you want to pick up a T1A disease, or before the T1A, the tumor which is not visible, but still you have the atypical cells in the cytology, there is a problem of lead time. In screening you have the lead time problem, so it is not translating into the clinical practice. Which patient you will evaluate, which patient don't evaluate. So that lead bias and lead time came into picture into sputum cytology. Even though it is simple, inexpensive, it is not a repeatable test, and acceptability are also very less. And there are trials on sputum cytology, and which was done previously, but it not picked up in a big way. But there are a few larger trials which came later on, had a baseline. They did a sputum cytology and chest X-ray. After that, they included in the LDCT versus chest X-ray group. But the trials which came later on, they found negative studies as far as the sputum cytology and chest X-ray are concerned. And the ideal choice as of today in the latest updated guidelines, as in the United States Task Force Preventive Study, as the guidelines versus the latest NCCN, the screening ideal choice in the targeted population who are high risk, those who have good health with a good expected life expectancy, is to submit them for a low dose CT screening, provided we have done good, the patient provider the consent is taken place in that point. In that point.
So yes, a screening tool should be the one which is has a good sensitivity. First of all, it should have a good sensitivity and a specific.
It should be specific.
Yeah.
It should have positive predictive value. It should have negative predictive value. But to satisfy this, it's very difficult.
Chest X-ray and cytology are not. They do not have very good sensitivity. In that case, LDCT is the best screening tool. It's a validity and the approved one for the lung cancer screening. So now we are going to screen our patient with CT scans, but a patient has come. He said, I am a smoker, but I do not have any symptoms. So convincing that patient for getting the CT scans, especially after the COVID era when there's a lot of scare of getting the CT scans, how are we going to convince the patient about the radiation exposure? So what are the technical specifications of low-dose CT scans, and how can we tell him objectively about the radiation exposure versus the standard CT scan and the chest X-ray? So Dr. Lakshmi, will you be able to tell us about this?
Yeah, simply trying to convince them for low-dose CT for screening is that the radiation exposure in low-dose CT is much lower. It is less than, say, 20% of what is the standard dose, 20 to 25%. And it is, in fact, almost equivalent to the radiation exposure of older generation X-ray machines. So the radiation threat per se should not be a risk factor for somebody who has been smoking. And that is one. So we can always bring in whatever the risk factors there are, existing ones, and it is not going to add much to the risk. The second thing is whatever the risk because of radiation they are going to bear, it is going to be reflecting some 15-20 years down the line. So what we are trying to do is we are trying to make him or stay healthy till that time. So the question only arises. So its success itself will be defined by the fact that it will have its implications for the patient's overall life or survival. That way, it becomes easy to convince. Convincing is not a problem as far as radiation goes. Other risk factors or other complications of false positivity and going forward is something which is going to be a bigger problem.
Definitely.
And I think we'll have to discuss them in detail.
Yes. So, means CT scan can be low-dose CT scans have a radiation exposure which is comparatively far less than the standard CT scans. Though it is little bit higher than the standard X-rays, but still it is acceptable, and it is that's why we call it a low-dose CT scan. It is recommended.
Yeah,
So my next question is for Dr. Ankit. Once the CT scan has been done and the patient comes back with the CT, so what are the things that we should look for that after seeing them we should be alarmed of, that yes, this patient has to be evaluated further? What are the different characteristics of the nodules which may be suggestive of malignancy?
So definitely once we have the CT scan, there are few things we have to see, that either patient is have any abnormality or not. And if the abnormality is that, what does he suggest? It is going for a benign or for a high chances of malignancy is there or not. So for benign, we all know that if any this popcorn calcification, there are so many other things are there. So if it is there, we'll see that it is a benign, and the chances of we basically we give a RATS scoring system, and we saw that it is generally RATS 1 or RATS 2, though, so he doesn't have to worry about that, and we will again screen afterwards. So if the patient has 2-3 things are there in their CT scan, then definitely we have to think about how the size, we have to measure the size, and depending on the size, we have to give them the right scoring, and we have to do the screening. So what we have to see first, it is if the patient has the nodules or not. So we all know that if the nodules has a spherical, by definition, if it is obscure, it is spherical, and their size should be less than 3 centimeter. And if it is there, nodule is there or not, if it is less than 3 centimeter, if the nodule is there, what kind of nodule we have? It is a solid nodule, or it is a partly solid nodule, or we have a ground glassing. So nodule can be 2 types. We call a solid nodule and subsolid nodule. And subsolid nodule, we have a partially subsolid nodule and is a ground glassing. So if the patient is the nodule size, depending on the nodule size and how we do take the size, it is also very important that when we taking the size of a nodule, we take 2 mean sizes, average of 2 mean sizes from the longest dimension. We have to take that, or we can calculate the volume of that. Right. So this is the ideal thing, and depending on the nodule size of if it is solid nodule or a subsolid nodule, or it's a ground glassing, if it is less than 3 centimeter or 3 to 6 centimeter, 6 to 8 centimeter, we give them the RATS scoring, and after that we ask them for we do the screening accordingly, that how the chances of malignancy is there.
Okay, so we are going to look for a nodule in the CT scan and then categorize them on the basis of the size as well as the characteristics, like whether it's solid, a partly solid, or the GGUs, and then measure it on the basis of the you are saying the average of the 2 diameters and or the volume, whichever is available.
Volumetric,
Yeah, thank you so much. So the patient has come back with a CT scan and there is a 6 millimeter nodule, and we the patient has a smoking history, the age fits in for the screening criteria. We got the CT cardiac biopsy for the patient, but it has come to be non-diagnostic. it is normal. So what are the complications of getting the subsequent test in a patient who does not have malignancy in reality? And what are the what is the chances of false positive rates? What are the implications in the course of the patient because it is going to pose a financial as well as mental stress on the patient. So what are the implications of over diagnosing and over investigating the patient in terms of screening the patients like that? So Dr. Logan, would you like to comment on this?
Yeah. You know, here, you know, we are putting a screening test. We are throwing this to a man, to a gentleman or lady who is in good health.
Good health, yes.
And we pick up something, incidental finding, and that puts the stress on the patient for the rest of the screening. So that's the problem with the screening. So we detect a lot of things unrelated to what we intend to screening.
Yes.
So the thing is, there are four dimensions on this. Firstly, you know, we pick up a lot of false positive things. One. Number two, if, for example, if you in the T0 year, for example, T0, the first year of low density CT screening, the T0, you pick up some nodule. Nodule has no calcification. If nodule has no calcification, partly solid nodule, and the solid part of the nodule, you know, the growth in the next subsequent year of screening, growth is less than 4 millimeter, and the no pleural effusion, no nodes, and no interstitial thickening, and no other the indirect signs suggestive or no contrast enhancement of the, you know, obviously you don't do contrast in this patient. So you don't have, if you don't have other indirect clues of the malignancy, you follow them up for the next year of screening. So obviously it puts anxiety, stress to the patient to the rest of the year of screening. One. And also the cost of screening, that can be discussed, you know, is it the screening procedure is cost effective or not. Coming to the, you know, the evaluating an abnormal nodule, it depends on various factors. Firstly, it depends on the, you know, nodule size is what very important. The nodule size, if it is, there are, you know, we have the newer lung rat score, you have LR 0, 1, 2, 3, 4. Anything, you know, the more than beyond 3 and 4, the risk of developing a lung cancer in the subsequent year or later on is more than 15%. Whereas if you have less than that, the risk of developing lung cancer in later years is less than 5%. So if you put these patients, for example, patient has, you know, the speculated nodule, for example, 12 millimeter peripheral nodule, you submit these patients for a procedure. It can be, you know, interventional procedure, it can be a surgical lung biopsy, thoracoscopic biopsy, whatever it is. The problems in this, in the complications related to evaluating a biopsy. The largest trial, the NLST, showed more than 90%, 95%, you know, nearly 90% false positive or not malignant. Out of this, so much of screening, more than 53,000 or so people who underwent NLST randomized trial, in the LDCT group had around 1,061 positive lung cancer. In the chest X-ray group, less than 900 plus patients underwent the procedure. Even though the relative reduction in the mortality is significant between the group, the procedure-related risk with reference to the life-threatening event, either it can be a cardiac or pulmonary or non-life-threatening event, for example, infection, bleeding, and so on, was very much, you know, documented in almost every studies. We have detailed report on this in the major trials, but the death due to the biopsy procedure is very less, even though it was less than, it was in single digit, whether you evaluate in the T0 year, T1 year, or T2 year with reference to the NLST, it is less than, you know, 10, you know, 5 patients, 4 patients, 3 patients. The debate here is whether they have died of a particular, with this procedure within 60 days or unrelated cause is the point for debate. But the point for discussion here today is, yes, there is definite, abnormal finding. If they submit this for a procedure to know what the nodule is, you have obviously procedure related risk. At the end of the day, majority are benign. Majority are benign. One. Number two, you diagnose certain cancers, overdiagnose. Patient has no symptoms, and some indolent cancers who have, the volume, doubling time is very, very far away. Obviously, some cancers may not, they give the symptoms in their lifetime. And even if you detect, may not require an aggressive therapy. But by submitting these patients for a screening procedure, you diagnose it and you overtreat it. So you have the problem of overdiagnosing a cancer which otherwise indolent, and you overtreat a cancer which otherwise requires on a minimum mode of treatment. So these are the problems with the finding an abnormal nodule in the screening test.
Yes.
And also, once you find an abnormal nodule, then you repeatedly submit these patients for a radiation exposure again yearly. If you talk with reference to NLS, even Nelson, first year, third year, fifth year, that is their protocol of screening. So the radiation risk related to the follow-up of abnormal lung nodule is also there. So these are the problems, to talk about very in short, the complications related to a diagnosis of a nodule and overdiagnosing it, cost, and what is the anxiety. But studies have specifically looked into the stress factor and anxiety, but they've come up with the data that it is short term, but the long term, it was not significant in terms of the stress factor. To answer the question in short, yes, we overdiagnose it. There are complications related to the procedure, and this is part and parcel, of the evaluating abnormal lung nodule. That's why this lung rods came later on, and if you increase the positive test criteria from 4 millimeter to 6 millimeter in the nodule, you significantly reduce the false positive test without compromising the number of lung cancer detected in that particular population. Indirectly, it reduces the number of procedures and also procedure related complications. And by more, and also the presently as against the time when the NLST was carried out, we are well equipped with the knowledge of evaluating these nodules with the current algorithm.
So we have seen Dr. Logan has very beautifully told that it has high false positive rates as well as there are chances of overdiagnosing. So is it really cost effective in our setting, especially in India, whether to screen for the patient with LDCT and imposing a financial burden? Dr. Ankit, would you like to comment on this, please?
Definitely. I think we all know that why we are taking the lung cancer as a screening, because everywhere it is a high burden, as well-established risk factors are there, symptomatic only in the advanced stages, availability of the effective therapy. So that's why we are doing the screening. And so we talk about the cost effectiveness. So let's see the how many patients are there in according to the New York criteria, like 50 to 80 years of we have to do that. So we in lung cancer, particularly in India, seen in younger ages. So 60% of the patients has less than 60 years of age. And so if we calculate overall, we have a 171 million people are there less than 60 years of age. And out of that, only 35 to 40% smokes. So still we have like more than 16 million people, if 16 to 18 million people are there for screening alone. So you can see that the burden and the logistic issues is very high, despite having. So that's why there in US, their median age is 70 years of age for lung cancer, where we have less than 50 to 60, between 50 to 60 years. So we have to do the screening very early. We had but sheer number of the cases we have to screen is very high. So definitely, how much cost effective is there is still the issue. We have and particularly in the second very important part that we belong to a TB endemic area.
Yes.
And we all other trials we have done, which is done in Brazil, the BREL trial and the Korean trial, K. Lucas trial, which they also had in a TB endemic area. And there they have shown that LDCT is not a very cost-effective and good for screening for lung cancer screening. The Brazil trial, BREL trial, and the K-Lucas trial. Even in India, we don't have a very big trials. One small trial has been done in Mumbai of 350 people, which has shown that the LDCT can be used. And very importantly, the very big trial is going on, which has been completed. All the recruitment has been completed from the PGIMR. More than 19,000 of the patients has been recruited in that. But the data is still not out. So how it is going, the PGI will be saying, Dr. Navneet will be telling us that what he has found, because we have a very good number of the patient for the screening. So, but if you see the mathematical basis, the cost, definitely the LDCT and the screening in India is not going to be cost effective. So how we're going to do, we'll be having an answer very soon by PGI people that will we'll have an idea.
So, as Dr. Ankit has told, that financial constraints are a very big factor, especially in our country where most of the people do have affordability issues. And on the other hand, what he has touched upon is the TB endemicity, which really confuses us. Things most of the patients do have a history of tuberculosis, and many of the times they do not have been treated. They do not know whether they have been infected with tuberculosis. So, how do we evaluate for such nodules in our country, especially where the TB nodules and benign nodules are very, very common? Dr. Mahendra, sir, please, would you like to comment on these? Sir, you are mute, sir. Yes.
Now this is audible?
Yes.
I listened to Nathan and Ankit about this nodule evaluation. So in the Asian population, if I go through this Western ACCP nodule evaluation of the Asian population evaluation, as is very well mentioned into the Asian clinical practice guideline. So to overall, it is long actually. 6 mm, we start with the 6 mm to the 8 mm, 6 to 8 mm, 8 mm, more than 8 mm, and 15 mm. So this is to divide this thing by the clinical express. If there is a nodule less than 15 mm, and there is the high risk group, we have to go for biopsy. If it is more than 15 mm, we have to go for the biopsy. But depending upon the nodule pattern, what type of the nodule is this? So they divided into the solid, part solid, and ground glass. So we have the Asian, we will put in the Asian pattern. There is a lot of difference in this geographical and cancer presentation. Many females having lung cancer, not smoking, never smoke. While in the western part, there are different the screen pattern design. Here, the design is different. So in the country, they have a different region. They have the different exposure, different type of the lung cancers also. So what we doing, if the nodule more than 8 mm or any follow-up CT scan, LDCT having any growth of more than 1.5 to 2 mm in size, and will come under the category of the high risk. So we can add or semi-solid more than 50% of this. So we have to go for biopsy. There are a lot of way of going to biopsy, and in the Asian population guideline, they says that we go for the PET scan if it is more than 15 mm or 8 mm, and the solid part is more than 50%. But the cost effective is very much important. We are the developing countries, and more importantly, what I feel that there is infection and granulomatous prevalence is more in Asian countries. So any nodule, we should think for the first for the benign or non-malignant. As Nathan shared the trial of that, the 9% of the nodule came to the benign condition. So I went to the China. We did 2 cases of pulmonary nodule diagnosis by transbronchial tunneling and with this Archimedes system. They came. I was surprised. I tell you that the nodule size was 20 and it came the fungal nodule. So I seen on the P-Rose technique on the slide. So that's why I go to the literature of the SCC guidelines, seeing that we have to look for the benign condition, or we have to look the evaluate the nodule by using there is what is this, whether they have the characteristic of the malignancy or not. Don't jump directly go to the biopsy and everything because
Yes.
there are we have to look for our patient pattern. There is no such expert panel believe that there are a lot of scope to add on our population pattern.
Yes. So basic idea is whenever we find a nodule, we should categorize them on the basis of the size and then low, moderate, or high probability, and then further decide. There are specific guidelines that are available which can be read.
So I think recent,
yeah, sir has told it briefly. Yeah.
Last 5 years, I've seen if the nodule, I've seen on the Facebook and other media that the nodule size is 12 mm, and we have diagnosed with this.
Oh, yeah, benign lesion.
So this should not be single. I have very single nodule, but many cases come with the benign, and so I was surprised there. It is not malignant, but this is the diagnosis. Benign condition is the diagnosis.
Yes.
One is inflammation, the diagnosis.
Yeah.
And,
yes. Another thing is,
guideline.
Another point that can be considered is the patient should always keep her previous radiology. We can always compare the present radiology with the previous. If the patient have, that would be quite useful in case of benign disease if the patient has. So coming on to the next question, sir, Dr. Loganathan. So what is the role of PET in all these lung screening cancer and in the TB endemicity country like ours? Where does PET stand?
Yeah, PET with reference to overall world population, PET with reference to overall, Indian subcontinent. Before that, PET, positive PET will not say that it is malignancy. It can be seen in other diseases also, especially in India. And one of the study which came from our institute, All India Institute of Medical Sciences, the PET, the value, the uptake is more even tuberculosis than in the malignancy, But before invoking this, the role of PET in a country like us, but generally, the role of PET later on, after all these studies, all these major trials in screening came on, to stick to the latest guidelines regarding the screening of lung cancer, the role of PET comes in certain areas. In LS0, the LR0, you don't do PET. In LR1 also, you don't do PET. When the nodule size is 6 millimeter, then you submit this high-risk asymptomatic patients for a subsequent LDCT. That's it. If the nodule size is, 6 to 8 millimeter, then depending on the case, either you can repeat the CT within 6 months or later on, depending on the high-risk behavior. Here also there is no role for PET. This is with reference to the evidence available as of today.
Mm-hmm.
The studies which were done with reference to the screening of lung cancer were done with the place in parallel with the CT scan. When this nodule which was found in the CT was said to be high risk, these patients submitted for PET and subsequent evaluation. And the sensitivity and specificity, positive predictive value, negative predictive value are also not superior than the LDCT. But in certain patients wherein nodule was found, the PET is away, then it picks up a disease in certain groups of patients. But coming to the role of PET with reference to nodule size, specifically between the nodule size between 8 to 15 millimeter. In these patients, when the nodule, if you pick up incident nodule and asymptomatic screening LDCT, if it is less than, if it is between 8 to 15 millimeter, either you do repeat the LDCT in the next 3 months, or depending on the case, you can ask for a PET CT in this high risk population. The PET is positive or a contrast CT is positive, then you evaluate this abnormal nodule of various means of getting a tissue sample depending on the location of the various things. But if the nodule size is more than 15 millimeter, then you ask either a PET CT or contrast CT. Ideally, now the present the placement of PET CT in the evaluation of oncological CT, people are moving towards PET CT, and you do PET. If it is avid, you sample it. So to answer your question, the role of PET in screening and in screening nodule in lung cancer comes when the nodule size is, if it is it 8 to 15 or more than 15, and you have history of smoking and other auxiliary features of the lung cancer, the malignancy. For example, you do a PET, you have a contrast enhancement of the nodule, you have the septal thickening, pleural effusion, pleural nodularity, and you have a nodule with this, which is FDG avid, yes, you go ahead with the sampling.
So basically,
yes. So in nodules in LR3, in LR3 and LR4, in the higher stages of lung RAD scoring, PET has a role with additional risk factors for lung cancer. At a standalone modality of lung cancer screening, we need more studies. It's a long way to go about it.
Right. So basically, the patients who are having a larger nodule, more than 8 mm, and has a high, moderate to high probability, these are the patients where you can think of getting the PET done for further evaluation.
Yeah.
So
that's what the latest NCCN also says about this. That's where it places the PET in the algorithm of evaluating these nodules.
Yes. Okay. So coming on to the next question, like what is the difference between the screening criteria for these smoking, and these are the criteria basically for the COPD patient. What about, do we really need to screen in the non-COPD patients because we have a lot of range of other respiratory diseases also? So is there any difference in the screening criteria or any difference in the false positivity? Dr. Lakshmi, would you please comment on this?
In non-COPD group, the false positivity rate is going to be much higher as compared to the COPD group. The criteria are not different. The common risk factors are included, whether they have COPD or non-COPD. Because they have one condition because of smoking, they are at higher risk of having another condition, which is lung cancer, because of smoking. So they tend to have the more true positivity and less of false positivity. So this is nothing but related to the denominator effect, where the risk is higher, you are likely to find more true positives and less of the false positives. If the overall risk is slightly lower, you are going to find more of the false positives and less of the true positives.
So in non-COPD patients, the risk of false positivity is a little bit higher than the non-COPD.
Definitely, it's going to be higher.
So just to end on our discussions, like I would just like to think, now we have just discussed what are the criteria, which modality should be used, which not to be used. But still, the lung cancer screening guidelines are still not very rampant in India. Most of us are not following them. If a patient who is asymptomatic, we are not deliberately screening them. So what are the barriers from the patient's perspective as well as from the healthcare perspectives that are there, that the lung cancer screening, as there are for breast cancer or cervical cancer? Cervical, we have PAP, which is very much into the screening part. And for breast cancer, there is mammo. But the LDCT is not into our routine practice. So what are the barriers? So, Dr. Mahedar, sir, please. So you are mute, sir.
What I understand by this, first of all, we need to understand what is screening actually. By doctor should understand this thing. Yeah, and he can understand and he should tell why this screen is going on? That we have to detect the population who are at risk. Number one. Number two, the detection of disease at early stage so that the treatment can be started early and the patient life expectancy can be increased. So what are the barrier is this? So we cannot take the LVCT in the India. For that, we cannot start everywhere the screening. That should be the committee should be designed. And like the Berasam who's working, I have seen him 30 years and I read the book when I was doing MD in 95. So such people should be come forward to make some strategy to have a good method for the early detection of the lung cancer. Number one. Number two, it has to be the screening is not a test to reduce the mortality or death from the lung cancer. It is the test by which we can evaluate the nodule that may have another test for the evaluation, and we have to go for to decrease the rate of malignancy in the population. So by which the reducing the cost, detection of the disease early, and the patient understanding. Patient should understand this is not going to decrease the death rate. It is from lung cancer. Patient need to understand this is the tool by which we can detect the disease early. But this process going on. If the patient not having, suppose the patient detected a small nodule 6 mm, and after 3 years regular screening of the annual screening, the size is not changed, and the patient come to you that what doctor you have made my so much of money to waste. So this patient should understand, health providers should understand. This should be the strategy for our population benefit and our country to be healthy like this. So we understanding is very much important for this. Patient provided decision making multidisciplinary action committee should be formed and guidelines should be formed in India for this lung cancer screening.
So the question remains open to other panelists. What would you suggest to improve the lung cancer screening ratio in our country, like the numbers for lung cancer screening?
I don't think it is for us at the moment.
Okay.
That's what I would go by at the moment. And as you rightly said, it is not yet into the clinical practice. It's just a reflection of why it is not so. The first and foremost is we do not have the local data available with us. There are so many things which needs to be different than what they have. They are there in the international recommendations. The first thing. Second thing is the denominator effect, as we just spoken of. We do have a lot of false positivity, and our false positivity rate is going to be definitely much more than what has been documented in any of the studies so far. Thirdly, we are not yet in a place where we can actually practice the evaluation of nodule at the same rigor, I would say. So we are still struggling to cater to the needs of the people who do have symptoms, and bringing in a large pool of people who do not have symptom, and then prioritizing their needs or care is something which is going to be an added burden. So for me, it is absolutely clear so far that it is not for us at the moment. Maybe 10 years down the line, it may be a reality for us.
But as Dr. Ankit earlier pointed out, there is a large number of population, high-risk population still available, still there, which we are not targeting, and lung cancer is so common. So I think this is the time to start the patients for lung cancer.
I think
India,
but there is a larger number
Indian
number
population
than what we are expecting who do have symptoms. They're not getting the care.
But most of these patients are at the advanced stage where we are not of we cannot offer much cure.
Cancer. I'm talking about the other diseases. So other disease burden where we can cater to them by minimalistic interventions or investigations or attention of ours, they are not getting what they really deserve. So bringing in another pool who are not yet symptomatic, and then see, and largely you also have to understand that this is largely targeted at decreasing the mortality. It doesn't take into consideration the morbidity, be it of the disease or be it of the interventions which we are going to do, and put them at increased risk of complications. All
Dr.
these things
Sweta,
have not
one
been
thing I want to
considered.
be added that we can at least what Dr. Lakshmikant is saying, definitely this one aspect is definitely there, that we are like an Indian scenario, we are not able to cater who are needy. We are
Yes.
still needy.
Okay.
So why we are going to waste our resources where like who are not still needy at that point of time. But just by saying that we are not the patients, we don't have the capability right now. There chance if there is chance we can save the lives. Definitely, it will be a very good thing to do that.
There has been mortality benefit which has been shown in the studies.
Definitely, and I think the best answer will be available once we have a local own data. So I think that the PGI data, once it will become, will be in a better position to answer that what kind of thing we like. They are doing more than 19,000 patients. So I think it's a very good pool. They have done, they have 2 primary objectives and 7 secondary objectives are there. So they have taken consideration of everything. So I think once that result will come, we'll have it in a good answer to that. But definitely, we can't say that way. If given the chances, if I can save any life, it will be better. So I think it has to be done, and we have to see the way. How can we do that? That will be my answer.
I want to. I agree with Lakshmi and Dr. Ankit. But my perspective is different. I'm thinking different. So I'm age 55. So I'm thinking you may be 35. So my thinking is different. My thinking is that Asian population together is very high. We are the very number 1 in the world. China, Asian, Taiwan, Hong Kong, Myanmar, everything. If we make the all population, this is very high, number 1. And advanced stage of diagnostic modalities technology we have. So why don't aaj nahi to kab? If it is not today, we are thinking for this, developing these things for the early detection for our people. I think this should be start, and he rightly said, Ankit, that the PGI is have a very good institution with us, and studies with us. So with this talk, the message should be go to them, and we start this screening tool for us. The government should take this step. Lot of thousands of crore of debt is taken big off by the government of India, right? For the kisan, जो हमारे farmers होते हैं. So why not this? We take the step for this. With my words, I want this. Everybody is going by CT scan, not only CT scan, PET scan, whole body scan. What does it mean? There should be guideline.
Dr. Behera, sir, please, closing remarks from your side, sir. What do you think?
Yes, I think the very nice discussion and all aspects were covered. But you see, I think maybe the speakers at the end, they summarized the things themselves. You see, what is, first of all, we have to understand what do you mean by screening? What is the purpose of screening? We have to understand the difference between a early diagnosis and screening. That is what I will approach the issue that way. Screening is something which, so that the patient is detected in a stage, much earlier stage, the treatment modalities should be available, and then his mortality is better. I mean the survival is better. So now I forget about the scientific part of it. Say, for example, if you do, as you said very rightly, if you use the criteria, of the what is the people do in the Western country. Our may be slightly different. So we have to first identify who are the people to be screened, who are the most affected. So we need to have a good epidemiological data. Of course, suppose we decide a particular age, particular smoking, you remember still there will be a large number, as I told you, in developing countries, non-smoking lung cancer is also a very common thing. Right? So we have to again define that who are those who are to be screened. Are you going to screen all the women who are exposed to the biomass fuel? So that will be another group which will be added on. This is one aspect. So that way the number will be enormous for this country who are otherwise will be eligible. But maybe we can compromise that. We can go to the most vulnerable. Then the second thing is about the LDCT. Do you know in your own hospitals, you see how much time it takes to get a CT scan done? Forget about the private sector or person spending money from his own pocket and getting a. So how many CT machines are there in the country? So that we have to develop those infrastructure so that that should be the priority. And the third thing, then the obviously very nice discussion about the interpretation of the nodules, what should be the size, what will be the. Then suppose suppose you get a nodule. So how are you going to diagnose? Again, the interventional radiologist or the other modalities they are required. Are we ready for that? Now the fourth and the last point, even if you have done everything, you decided, okay, I have got now detected a case, it is stage 1 lung cancer or stage 2 lung cancer, then do you think you have got enough surgeons will take care of them? So you make a diagnosis for me that I have got stage 1 cancer, lung cancer, but then I don't get a surgeon in my city, then where do I go? So what should I do with it? So I think while all other academic discussions were very
So these are the barriers.
These are the barriers. So you have to take these things, all these things in account before thinking of academic research is a different issue. You can do academic research. So let us see. I think Navneet has already started this one. So all these questions will be answered there. So the question is, the getting a CTVS, I do not know if the things have changed now in PGI, but getting a surgery done, you wait for 1 month, then he comes, give the bed, they are more interested for some other surgery. So if I am detected with stage 1 cancer and I wait for 2 months for a surgery through a CTVS surgeon, then what is the idea of the entire philosophy behind the screening of cancer is defeated. I am sure these are the other issues which you have
Yes, sir. Yeah. So I think talking with the patient is very, very important, whether he would rather go for the surgery in the future or not. And I think the take-home message would be to do the lung cancer screening wherever possible, though we are in a resource-constrained country and TB and MSCT. But the take-home message, especially for for us also and for the listeners also, is to do it as far as possible. If you have the resources, and though there are constraints, we should develop the data is coming from the PGI Chandigarh. Let's wait for that and to have better, strong evidence, better backup, and better confidence that yes, we have to do it. But yes, but the 3 criteria should be taken into mind whenever a patient comes to you. Yeah. Thank you so much. So already we have 25 minutes late. And so I thanks Dr. Behra sir for.
So there are still controversies in screening. So
controversies will remain, I guess.
Yeah.
So I thank all the panelists, Dr. Behra sir, for the very nice discussion, sir. And I thank you for the listeners. I think the question answers has been taken over by yes, it has already been taken care.
The topic itself was controversies. We have to keep the controversies alive by end. If we could solve the controversies by 1 hour's discussion, there wouldn't be any need for research. But yes, the Indian data or the local data is something which is
needed.
Which is required.
And not only on one aspect. So even if the screening gives us a data about one aspect of it, the follow-up data is absolutely required to understand, does it really make the difference? Because most of our patients are not going to be happy with even 1% or 2%. Most of them want 0 or 100%. So 0% risk, 100% reserve. So we have a peculiar expectation. So we have to be sort of keep things as much covered as possible. Anything which is exposed, they expect 100% out of it.
So I think let's finish up it off. It's already 9:30. So thank you so much, panelists. All the panelists, Dr. Behera sir, Dr. Richa ma'am is still there, I think. So thank you, Glenmark, and thank you all the listeners. Good night, everybody.
Thank
Thank
you. Thank you.
Thank you.
It's
Thank you.
12 a.m. here in Taiwan.
Oh,
Taiwan.
so good morning to you.